Good morning, all. My presentation topic is dry eye evaluation in thyroid eye disease. Aim of my study is to evaluate the dry eye in patients with thyroid eye disease using various tests of dry eye. Dry eye is a common association of thyroid eye disease and a common cause of morbidity. So, in patients with dry eye symptoms, ophthalmologists can play a primary role in diagnosing the thyroid disease, and hence dry eye evaluation is very relevant in such cases. Considering the consequences of dry eye, it is important to prevent these complications by diagnosing and treating the dry eye earlier. All patients diagnosed with thyroid eye disease presented during the study period were selected for my study, and patients with allergic ocular surface diseases, duct abnormalities, contact lens users, pterygium, pseudopterygium patients, patients on topical anti-glaucoma medications, those with other systemic diseases causing dry eye were excluded from the study, and the subjects diagnosed to have thyroid eye disease attending ophthalmology OPD of Government Medical College Kottayam during a study period of 1 year were included, and these patients are documented thyroid disease patients irrespective of their thyroid status with lid retraction and any of the features like a restriction of extraocular movements, exophthalmos, and optic nerve dysfunction. We totally got 91 subjects during the study period, and all underwent a sequential history taking, detailed ocular slit lamp examination, and dry eye evaluation tests like Schirmer test 1 and 2, tear film breakup time, ocular surface staining, and impression cytology. Dry eye was diagnosed in those with subjective symptoms of dry eye and any one of the positive diagnostic tests, Schirmer test less than 10, tear breakup time less than 10 seconds, impression cytology grades according to the Nelson criteria more than 2 and 3, and Rose Bengal stain with the Van Bischoffer score more than or equal to 4. Results of my study: the prevalence of dry eye in thyroid eye disease was found to be 63.7%, and among 58 subjects diagnosed with dry eye in thyroid eye disease, 68.1 were females and 31.9% were males. The Schirmer test results shows 96% of Schirmer 1 was normal, and in 4% subjects it was abnormal, and Schirmer test 2 was normal in 82% of the subjects, and in 18% it was abnormal. About the T-BUD test results, among total subjects of thyroid eye disease, 60.4% had abnormal T-BUD values. Of this, 39.6% had marginal dry eye disease, and 20.8% had definitive dry eye, and T-BUD was normal in 39.6%. Rose Bengal staining result study revealed 58 cases of dry eye had a Bischoffer score more than or equal to 4, that is positive, revealing 100% of cases with dry eye had a positive Rose Bengal staining. Impression cytology results shown among total of 91 subjects, 53 subjects, that is 58.3%, had abnormal findings in impression cytology, and among the dry eye disease diagnosed ones, it is 91.4%, which have decreased goblet cell density, decreased NC ratio, and desquamation. The prevalence of dry eye disease in thyroid eye disease in my study was 63.1%. And in a study conducted by Jessica H. Selter, the relationship between Graves' ophthalmopathy and dry eye syndrome, the prevalence was 65 to 85%. And in a study by Novak et al., the dry eye symptoms were present in 85% of thyroid ophthalmopathy. In this study, 93.1% had normal Schirmer test 1 and 70.7 have normal Schirmer test 2, suggests that tear production is not much affected. But in Novak study, the Schirmer tests were significantly lower than compared to the control group. Similar result obtained in study by Jessica H. Selter. On analyzing the result of T-BUD, among all cases, it revealed 55 cases with abnormal T-BUD, of which 62.1 had marginal disease, dry eye disease, and 32.8 had definitive dry eye. In study by Jessica Seltar and Extin et al., similar results were obtained. On analyzing the results of impression cytology, among 91 subjects, 53 had abnormal findings. In study by Extin et al., impression cytology in Graves' ophthalmopathy and dry eye patients showed a reduced goblet cell density, reduced nucleocytoplasmic ratio, excessive desquamation in conjunctival cells compared to the normal controls. My references are these.
So every patient had all these 4 tests.
Yes, madam.
What's the order in which you did these tests?
First Shermer test 1 was done. Then tear film breakup time and Shermer 2 was done.
I think once you do the Shermers and then you do T-BUT is acceptable?
No, T-BUT is done, then Shermer 2 is.
That should be the order. And did you correlate it with the clinical activity or VISA score?
Madam, in this study, I only proceed with the dry eye evaluation alone.
Agreed, but you are seeing the patient as a whole, then you know that what was the severity of the thyroid eye disease they were having, isn't it? Every patient will have this score.
In patients with active disease,
To say, is there any correlation between the severity of the dryness to the activity score?
This was positively correlated. In this part only the evaluation of dry eye was done.
You didn't correlate that with the severity of the thyroid eye disease, no?
No, madam.
No, that should be.
Good afternoon. My study was on the topic diagnostic accuracy of Van Herk technique compared to gonioscopy in detecting primary angle closure suspects among eclipsine positive cases. The prevalence of primary angle closure glaucoma is high and it may be prevented if occludable angles are identified earlier. Instead of time-consuming procedure like gonioscopy, we need simple procedures like eclipsine and Van Herk technique. This was a hospital-based cross-sectional study in patients of age more than 40 years with positive eclipsine attending our OPD from November 2019 to April 2021. Those with diagnosed glaucoma, primary angle closure disease, secondary causes for angle closure glaucoma, and previous history of ocular surgery and injury were excluded from the study. The primary objective was to study the diagnostic accuracy of Van Herk technique in detecting primary angle closure suspects compared to gonioscopy in eclipsine positive cases. And the secondary objective was to study the influence of corneal white-to-white diameter, central anterior chamber depth, lens thickness, and axial length in detecting primary angle closure suspects. 200 eyes of 100 patients were included and all of them underwent Van Herk grading and Schaeffer's gonioscopy grading. Those with iridotrabecular contact more than or equal to 180 degree was considered as positive in gonioscopy. Corneal white-to-white diameter, corneal central anterior chamber depths, lens thickness, and axial length were measured. Lens position, relative lens position, and ratio of lens thickness axial length ratio were calculated, and these were analyzed using SPSS 20 software. Independent t-test, ANOVA test, and ROC curve analysis were done. P-value less than 0.05 was considered as statistically significant. Coming to the results, majority of them were females, which was 66%, and highest number was in the age group 51 to 60 years, which was 39%. 141 eyes were turned out to be positive in gonioscopy. 90.6% of Van Herk's grade 1 eyes were positive. In age group 71 to 80 years, all of them were positive. 80.9% of males and 65.2% of females were positive. With the cutoff of Van Herk's grade 2, sensitivity was 95.04 and specificity was 33.9. With the lower cutoff, it was 61.7 and 84.75. The mean axial length and corneal white-to-white diameters were significantly smaller in females, and lens thickness, lens position, and lens thickness axial length ratio were more in males. Lens thickness was higher in each group 71 to 80 years, and mean axial length was significantly lower in each class 41 to 50 years. The ROC curve of lens thickness and lens thickness axial length ratio showed area under the curve more than 0.5, but both were statistically insignificant with a p-value more than 0.05. The proportion of females was more in the younger age groups and they had significantly lower axial length and corneal diameter. The proportion of males was more towards older age groups and they had significantly higher lens thickness, lens position and lens thickness axial length ratio. The majority had Van Herrick's grade 1 as only eclipse and positive eyes were included. In a study conducted by Chowdhury et al., which included both narrow and open angle clusters, the majority were Van Herrick's grade 3. The maximum number of disease positives were in the age group 51 to 60 years, same as Chennai glaucoma study. The proportion of males becoming positive was more than females, which may be due to larger lens thickness, lens position and lens thickness axial length ratio in males compared to females in the sample. In our study, with a cutoff of Van Herrick's grade 2, the sensitivity was 95.04 and specificity 33.9. With a lowered cutoff, the specificity increased to 84.75%, which was comparable to the study done by Chowdhury et al. To conclude, the Van Herrick technique can be used as a screening test to detect primary angle closure suspects among eclipse sign positive eyes with a sensitivity of 95.04%. With the cutoff of Van Herrick's grade 1, the specificity increases to 84.75, for which we can consider prophylactic laser peripheral iridotomy even without gonioscopy. In younger age group, shorter axial length is a risk factor for primary angle closure suspects, and in older age groups, increased lens thickness is contributing more to the risk of developing PACS, and hence early lens extraction can be considered in this age group. The biometric values and the derived values give additional information about the risk of developing primary angle closure disease. The limitations of the study are small sample size and inter-examiner variations in Van Herrick grading and eclipse sign test. These are my references and thank you.
Okay, did you do peripheral iridotomy in any case without gonioscopy?
Usually we don't do.
No. In your study, did you do for any patient?
No.
Is it advisable?
No. According to the available studies, it is not advisable. Without confirming by gonioscopy, we cannot proceed into peripheral iridotomy. But this was an attempt to study whether we can proceed to peripheral iridotomy even without gonioscopy, like time-consuming procedure.
Gonioscopy is not a time-consuming procedure at all.
It need more experienced ophthalmologist to perform gonioscopy.
Every other PG student or resident should be well versed in doing a gonioscopy.
Madam, in a busy OPD like ours,
You
gonioscopy
cannot
is...
say busy.
Yes,
Your conclusion is that in men, it contributed to the cataract. So is there any point in doing laser in them?
No, madam.
So you cannot make a generalized
yes,
statement like when it is Van Herrick's grade 1, laser iridotomy, no. There are other underlying causes of shallow AC.
Yes, madam. Madam, males, most of them were in the older age groups and in them lens thickness was more. We advise, yes, ma'am.
You cannot conclude it like that. That's not acceptable. What percentage of PACS go into angle closure?
Around 10%, 7%.
Less than that. So that means to avoid that many angle closures, you have to treat these many patients. No.
Yes, ma'am. Thank you.
Why did you include both the eyes?
Because it is a bilateral disease. Okay.
One, was all the observation done by a single person? You said in the end only you revealed that there was an inter-observer variation.
Yes, ma'am. Madam, it was done by a single person. No, madam, it was done by a single person.
Back was that inter-observer variation.
What I meant was if another person is doing it. Okay. Okay. Thank you, ma'am.
Good morning, everyone. So today my study is about steroid-induced ocular hypertension, mean change in intraocular pressure from baseline. It is a prospective study. The background and rationale of the study: oral steroids are life-saving drugs used for many systemic conditions like connective tissue disorders, bronchial asthma, COPD, post-renal transplant. Secondary steroid-induced ocular hypertension is a silent risk factor for glaucomatous optic neuropathy, which causes irreversible blindness. It's well established that topical steroids can produce ocular hypertension and steroid-induced glaucoma. This study is intended to address a deficiency in literature regarding mean change in IOP with oral steroids over a period of use. Objective of the study: primary, to study the mean change of intraocular pressure from baseline to 6 months following oral steroid use. Secondary, to assess the type of responders based on IOP response to steroids and classify them into high, moderate and low responders, and to compare the type of steroid response with duration of use and dosage of steroid. Materials and methods. The study design was a prospective study. Study period was from September 2020 to May 2022. Study subjects were the patients who were planned to start on oral steroids, and study setting was in the Department of Ophthalmology at a tertiary care center in South India. The inclusion criteria was: the patients planned to be initiated on oral steroids with minimum expected duration of 6 months and the patients above 18 years of age. Exclusion criteria were the patients already on IOP lowering agents, either topical or systemic route. All other steroid routes were excluded: patients with narrow angles and prior ocular surgeries. The methodology: a pilot study was conducted and we checked the intraocular pressure of 10 samples prior to starting of oral steroids at 1 month, 3 months and 6 months for sample size for oral route, and 92 samples were derived. Complete ophthalmological examination was done for the study population, and they were classified into non-responders and steroid responders. Steroid responders were then further classified into low, intermediate and high. Classification that is used in the study is a Mali classification, with low responders as 6 mm mercury, intermediate as 5 to 15 mm mercury, high more than 15 mm mercury. EULA standardized nomenclature was used for the corticosteroid initial dosage. Low dose was 7.5 mg of prednisolone equivalent per day, medium dose was 7.5 mg to 30 mg milligram of prednisolone equivalent per day, and high dose was 30 mg to 100 mg, very high dose was 100 mg, and pulse therapy 250 mg. The criteria for treatment of steroid-induced glaucoma was taken from study of Francois, with the topical route being a check at 2 weeks, systemic route a check at 4 weeks, depot was checked at 1 week. If the IOP is more than 21 mm mercury, regular review initially 2 months, then 6 monthly. Other signs of glaucoma is the pressure more than 30 mm mercury, then stop steroid if possible and start first-line medical treatment. In uveitic glaucoma, avoid prostaglandins and reduce steroids if possible, and recheck IOP at 4 weeks. If IOP was increased, add further medical treatment, and is IOP less than target, then recheck at 6 months. And if maximum medical treatments, yes, we have to consider the surgery or cyclodistraction. Our results were: 86 eyes of 43 patients were studied. 73% of the population were females and 27% of the population were males. Mean age of population was 39.03 plus or minus 14.27. The initial dosage of steroid usage that was in this study was 2.5 mg, 5 mg, 10 mg, 20 mg, 30 mg and 40 mg. Mean change in IOP from baseline to 6 months. Mean IOP at 0 was 16.86, at 1 month was 16.94, at 3 months was 16.97, and at 6 months was 17.90, with a mean change of 1.1, and it was found to be significant. The underlying disorders for which the steroid was used was in autoimmune hemolytic anemia, Behçet's, GPA, Sjogren's syndrome, CKD, polyarthritis nodosa, rheumatoid arthritis, dermatomyositis, sarcoidosis. Mean change in IOP from baseline to 6 months, with different dosages at initial administration, with 2.5 mg, which was showing a mean change of 0.56, 5 mg was showing 0.45, 10 mg was showing 0.52, 20 mg was showing 1, and 30 mg 1, and 40 mg was showing 0.75. The trend analysis of IOP with 2.5 mg showed that when a 2.5 mg dose was continued over a period of 6 months, there was an increase of IOP from mean of around 1 mm mercury. With 10 mg dose showed that over a period of time when it was reduced to 2.5 mg, there was a decline in the IOP. With the 20 mg dose also we made a similar observation, and with the 30 mg, the dosage was considered in one patient of post-renal transplant, and he was continued on 5 mg, there was an increase in IOP to 1 mm mercury. With the 40 mg dose, which was further declined to 2.5 mg, showed a decline in IOP. The study from Southampton Eye Hospital was considering a discussion about my studies. Study from Southampton Eye Hospital showed they took a cases of 34 patients and found non-response to be 64%, low responders to be 20%, and moderate to be 16%. And in my study, everyone were low responders. In an article that is published on Canada Journal of Ophthalmology, studied a group of 3 patients with connective disorders with low-dose steroids and without steroids and healthy individuals. And they found that there was no difference in IOP over a period of 6 months when low-dose steroids were given. Our observations, there was statistical significance in mean change in IOP from baseline to 6 months. It showed that there was no much change in mean IOP with oral steroids, and it is safe for administration provided a close follow-up is done to ensure that patient is monitored for IOP, gonioscopy and disc changes. The limitations of a study were that due to COVID pandemic, there were lost follow-up and data deficiency. Duration of study was restricted to 6 months, and we suggest a cross-sectional study with more samples and longer duration will provide more information regarding effect of oral steroids on IOP. These are my references. Thank you.
Would you like to use the term ocular hypertension for steroid induced, or is it glaucoma itself?
Steroid-induced ocular hypertension, ma'am. With the disc changes, we will say glaucoma. It is a broad spectrum term.
Okay. And what is the dose? Is there a relation between the dose of steroid and the onset of steroid-induced glaucoma?
In my study, I couldn't find any connection with that, ma'am. But in my study, the patients who were started off an initial dosage of 40 mg, and when they were reduced over a period of time, they are not on the same dose. They are reduced to 30 mg. Then in the next follow-up, they are reduced to 5 mg and 2.5 mg. We found a further decrease in the IOP early. But if it is going to be continued in a very high dose, then yes, there will be an increase in IOP.
Which topical steroid you studied?
Not topical, I only studied on systemic
only
route.
systemic, okay.
How many of them had ocular involvement due to underlying disease?
Like uveitis or something, there was nobody was there. Because I was excluding the people with topical steroid usage also. My study only included oral steroids.
Okay, then why were they referred to ophthalmology?
Basically because they started on systemic steroids and they want to know if there is any ocular involvement also.
Ocular involvement. And in your conclusion, you said follow up with the IOP, gonio and disc changes.
Yes, ma'am.
What do you expect to see in the gonio on follow up?
If there is steroid-induced ocular hypertension and if the patients are developing very high IOP and then they are developing angle closures.
Angle closure?
Not all on a sudden, like
what is the mechanism of steroid-induced glaucoma?
There are different mechanisms, ma'am, in that it is depending upon the receptors that are there in the trabecular meshwork. The response to them is high.
So basically it is like an angle closure or an open angle?
Open angle glaucoma.
So is there a role for gonio?
Yes, ma'am.
Why?
Because I can exclude the patients who are coming with closed angles. I don't know if the patients already had an underlying glaucoma.
Then will you contribute it to the steroid?
No, it won't contribute to steroid.
Okay.
Thank you.
Good afternoon. My topic for paper presentation is optical coherence tomography based subtypes of diabetic macular edema and its association with systemic risk factors. Moving on to the background, diabetic macular edema is the most common cause of visual impairment and blindness among patients with diabetes mellitus. Optical coherence tomography is a high resolution imaging technique that provides cross-sectional image of the retina and plays an important role in evaluating and managing diabetic macular edema. Systemic risk factors like hypertension, dyslipidemia, nephropathy can worsen diabetic macular edema. A good understanding of the systemic risk factors that can affect the development of diabetic macular edema is helpful in the management. The OCT-based classification of diabetic macular edema, we have classified into diffuse type where there is spongy thickening, cystoid type where the cystoid-like cavities, serous macular detachment type, tractional type and mixed type which can be a combination of the above types. The purpose of a study is to assess the spectral domain OCT-based subtypes of diabetic macular edema and its association with systemic comorbidities. The materials and methods, it was a retrospective cross-sectional study which was conducted in a tertiary eye hospital in central Kerala. 100 consecutive diabetic macular edema patients who underwent ocular examination and SD-OCT from Jan to May 2022 were included. The inclusion criteria were the eyes with clinically detectable macular edema having good quality SD-OCT images and central macular thickness more than 300 microns which can be attributable to diabetic macular edema. The demographic data and information regarding the systemic comorbidities like hypertension, dyslipidemia, coronary artery disease, nephropathy and anemia were collected from the medical records. Best corrected visual acuity, slit lamp examination, dilated fundus examination and S2 OCT were done for all the patients. Moving on to the results, the demographic data, out of the 100 DME patients, the males were 51 and females were 49. The mean age group of the study was 62 plus or minus 5 years. In the best corrected visual acuity, we found the cystoid subtype had the worst best corrected visual acuity. In our study, we found that the cystoid subtype was the most common type, followed by diffuse. Then we had the tractional, SMD. The central macular thickness was the maximum in the mixed subgroup, followed by the SMD. Then we had the cystoid, diffuse, and tractional. The comorbidities which was present in our study population was the hypertension was the most prevalent one, followed by dyslipidemia. Then we had kidney disease, coronary artery disease, and anemia. We found that there was a significant association between the hypertension and the DME subtypes. We found that the p-value to be 0.019, less than 0.05, and it was considered statistically significant. The association of dyslipidemia, anemia, coronary artery disease, and kidney disease, we could not find any significant statistical association. We also analyzed the ellipsoid zone loss in all these patients, and we found that 58 out of the 100 patients had ellipsoid zone loss, and the maximum ellipsoid zone loss was seen in the cystoid subgroup, followed by the tractional, diffuse, mixed, and SMD type. Discussion. In a study by Sana et al., DME had been classified into diffuse, cystoid, and subretinal fluid pattern based on the OCT. In that study, the diffuse retinal thickening was the most common type. In our study, cystoid type was the most common type. In the previous study, the central macular thickness was maximum in the cystoid subgroup. In our study, it was maximum in the mixed subgroup. In the study by Alcora et al., the worst BCV and the highest CMT was in the CME subgroup. In our study, the worst BCVA was in cystoid subgroup, which was consistent with the previous study. Aditi et al. Had stated that high BP was a significant risk factor for SMD. In our study, there was significant association between hypertension and DME. In a study by Durgan et al., micro or macroalbuminuria was seen as a statistically significant higher rates in patients with DRT. In our study, we could not find any significant association between the types of DME and nephropathy. So, moving on to the conclusion. In our study, cystoid macular edema was the most common subtype of diabetic macular edema. Worst best corrected visual acuity and ellipsoid zone loss was seen in the cystoid subgroup, which helps in the treatment decision and prognosis. Systemic hypertension was the most common comorbidity, and it was found to have significant association with the diabetic macular edema subtypes. These are my references.
Diabetic retinopathy?
Mainly the systemic risk factors like hypertension, dyslipidemia, nephropathy, anemia.
No, you're forgetting the basic disease.
The control of diabetes mellitus needs to be is the most important.
But your study, nowhere you have included that the most important risk factor, that is the control of diabetes. Isn't that the most important?
Yes, ma'am.
And duration of diabetes also not included.
No, nephropathy is not associated, you said.
We could not find any significant association, statistically significant.
But the common understanding is nephropathy is related to the retinopathy.
Yes, ma'am.
Renoretinal, no? Renoretinal disease.
Yes, ma'am. Yes, ma'am.
There is a definite association.
Yes, ma'am.
Okay, good morning. My study is changes in central macular thickness after cataract surgery in patients with and without diabetes mellitus. Diabetic patients may develop macular edema post-cataract surgery. It can be either the diabetic macular edema or the pseudophakic cystoid macular edema, and the pseudophakic cystoid macular edema may develop in otherwise healthy eyes post-cataract surgery. So, macular edema is now regarded as one of the most common cause of visual loss after an uncomplicated cataract surgery. Hence, it is important to quantify the macular thickness changes before and after cataract surgery. The optical coherence tomography (OCT) is a non-invasive method of quantifying the macular thickness. This is an OCT image showing macular edema with increase in the central macular thickness. The aim of my study was to evaluate the changes in the central macular thickness after an uncomplicated cataract surgery in patients with and without diabetes mellitus using the OCT. Materials and methods. This is a prospective comparative study conducted at a tertiary care institution in Kerala. and the study period was 1 year. The inclusion criteria included patients having senile cataract with media clarity to obtain a clinically interpretable OCT image and preoperatively normal fundus or presence of diabetic retinopathy without macular edema. Exclusion criteria included previous history of any intraocular surgery, presence of any retinal or choroidal diseases other than diabetic retinopathy, history of treatment for diabetic macular edema or proliferative diabetic retinopathy within 6 months prior to the surgery, or any intraoperative complications, any postoperative complications other than macular edema. About 50 patients were included in this study, and the patients were classified into two groups. Group 1 included 25 eyes of patients with diabetes mellitus, and Group 2 included 25 eyes of patients without diabetes mellitus. And all these enrolled patients, after getting an informed written consent, underwent a detailed history taking and baseline ophthalmological evaluation, including visual acuity, slit lamp examination, and a dilated fundus examination using indirect ophthalmoscopy. After the fundus examination, the patients with diabetes were classified into patients having no diabetic retinopathy with mild non-proliferative diabetic retinopathy, that is mild NPDR, moderate NPDR, and severe NPDR, based on the International Clinical Diabetic Retinopathy Disease Severity Scale, and a preoperative baseline OCT macula evaluation was done using radial scan using the Topcon Maestro OCT machine. And after an uncomplicated phacoemulsification cataract surgery, all these patients were followed up postoperatively using an OCT macula at 1 month, 2 months, and 3 months. Coming to the results, both these groups had a comparable age distribution. At maximum, patients were included at 61 to 70 years, with a male preponderance in both the groups, with 64% in diabetic group and 72% in non-diabetic group. Coming to the lens status, both groups had a comparable lens status, with maximum patients included with nuclear sclerosis grade 3 and posterior subcapsular cataract. The diabetic retinopathy status of patients in the diabetic group had 16% of patients having severe NPDR, 32% each with moderate NPDR and mild NPDR, and 20% patients were not having diabetic retinopathy. Coming to the comparison of mean central macular thickness, within each group, the mean baseline CMT showed an increase to the mean CMT at 1 month, 2 month, and 3 month postoperatively from the baseline values, which was statistically significant. And in each group, the increase in mean CMT from postoperative 1st month to 2 month, and the decrease from 2 month to 3 month was also statistically significant. And on comparing the mean CMT between the groups, the baseline mean CMT values change was not statistically significant between the groups, but there was a statistically significant difference in the mean CMT values in the group 1 compared to the group 2. And at the 1 month and 2 month, the difference was statistically significant, but at 3 month postoperatively, the difference was not statistically significant. Comparing the mean CMT values with the diabetic retinopathy status of the patients, at the baseline, the mean CMT values were not much different among the groups having no diabetic retinopathy and mild, moderate, or severe NPDR, but the mean CMT values were increased in all the groups at 1 month, 2 month, and 3 month postoperative period, which was statistically significant, and the increase was more in the severe NPDR group. Coming to the discussion, in a study by Ikegami et al., it was showed similar result with increase in the postoperative CMT values at 1 month, 3 month postoperative visits in both the groups, and which had higher values in the diabetic group, but the significant difference was not noted between both the groups, but it was different from our study, which showed a significant difference between the groups, and peak value of increased CMT was noted at 1 month in a study by Kohn et al., but we had obtained comparable values with our study in another study by Gabriel et al., which showed increase at 2nd month. And also in a study by Kim et al., the diabetic retinopathy status are compared and showed an increase in mean CMT more at the severe diabetic retinopathy values. So the conclusion is that increase in the macular thickness occurs in both the groups after cataract surgery, and the amount of increase depends upon the retinopathy status of patients with diabetes mellitus. These are my references. Thank you.
Was all the surgeries done by a single surgeon?
No, ma'am.
So that is a bias, no?
Yes, ma'am.
There is a difference. Did you, all surgeries were uncomplicated?
In the cases taken in our study was all uncomplicated.
Okay.
How did that macular thickness came down at the end of 3 months? Was there any change in the treatment?
No, ma'am. Treatment was not taken. In the third month,
What is your post-op regime?
post-operatively, we used to give topical antibiotics and topical steroid since 3 months, up to 3 months, and a topical nepofenac was given for diabetic patients.
Correct. So, if you have put the patients with only one group on nepofenac,
Yes, ma'am.
do you think it's acceptable?
No, ma'am, that's a limitation.
Nowhere you brought up that.
Thank you, ma'am.
So good morning. My title is a retrospective case series analysis of clinical features and therapeutic outcomes in rhino-orbitocerebral mucormycosis in a tertiary care center. Introduction: mucormycosis is a rare opportunistic fungal infection that mainly affects diabetic and immunocompromised patients. It reached epidemic proportion during India's second wave of COVID-19, so with several risk factors. The management includes control of metabolic abnormality, administration of systemic antifungals, and surgical debridement that range from simple sinus clearance, radical debridement, and orbital accentration. We analyzed the clinical records of 17 patients admitted with the rhino-orbitocerebral mucormycosis during COVID-19 pandemic at our institution. The objective was to evaluate the clinical features, imaging characteristics with extent of disease and therapeutic outcomes in rhino-orbitocerebral mucormycosis. Materials and methods is a retrospective case series study of 17 patients admitted with radiologically and histopathologically confirmed cases in Government Medical College, Kottayam from January 2021 to April 22. Case where etiology couldn't be confirmed by microbiology or histopathology. Records with incomplete data were excluded from this study. Data regarding clinical presentations, imaging, therapeutic interventions, and outcome at discharge were collected from the records. So for the purpose of analysis, the mucormycosis was classified based on the site of involvement into 3 groups. Clinical stage 1 includes sinonasal disease, clinical stage 2 include rhino-orbital disease, and clinical stage 3 include rhino-orbitocerebral disease. And according to treatment given, they are classified into 3 groups. Treatment group A includes sinusal debridement with plus IV liposomal amphotericin B, and treatment group B includes treatment group A plus local amphotericin B injection, that is 1 ml of 3.5 mg per ml for 14 days. Treatment group C includes treatment group B plus accentration or intracranial surgeries. Based on the outcomes, people are divided into 3 groups. Group 1 is improvement with recovery, group 2 is improvement with sequelae, group 3 is progressive disease with complications. So results are, out of 17 patients, the mean age is 59.4 with a male preponderance of 71%. The common signs and symptoms include, the symptoms are most commonly the facial pain and swelling, followed by nasal discharge and defective vision, and headache and diplopia. The signs include nasal and palatal crusting, necrosis of turbinates, proptosis, conjunctival chemosis, ptosis, and CRIO, and CNS signs are altered mental functions, cavernous sinus thrombosis, and hemiplegia. The clinical stages, there are 5 patients included in clinical stage 1 and 2, and 7 patients included in clinical stage 3. Disposing conditions, all patients had uncontrolled diabetes mellitus with underlying disease. The 10 patients had a history of recent COVID-19 infection, out of which 7 patients received systemic steroids. Patient in treatment group B and C had more severe metabolic rearrangement, with some patients having more than 1 underlying diseases. So diagnosis is the evidence of maxillary and ethmoidal sinuses present in all patients, and the features of preseptal edema, proptosis, middle thickening, orbital wall erosions, and minimal obliteration of fat shadow is seen in 12 patients, and intracranial disease on CT included cerebral infarcts, basal ganglia, and cavernous sinus thrombosis meningitis. The medical treatment given all patients received intravenous liposomal amphotericin B for a cumulative dose of 3 to 5 gram as soon as the diagnosis of mucor was established. Local amphotericin B, it is 1 ml of 3.5 mg per ml for 14 days into the orbit, was administered in 12 patients in clinical stage 2 and 3. Surgical treatment includes all 17 patients underwent debridement of all necrotic tissue in the sinuses and the nasal cavity. 9 of 17 patients with a rhino-orbital disease underwent sinus debridement along with the local amphotericin B into the orbit. The remaining 3 patients in the clinical stage 3 disease underwent orbital accentration with extensive sinus debridement. So treatment group A includes 5 patients, and B includes 9 patients, and C includes 3 patients. The outcomes, the patient underwent treatment A had a successful outcome 100%, and 5 patients with rhinoorbital disease and 4 patients with rhinoorbital cerebral disease underwent treatment group B, and the disease improved with sequelae like defective vision, loss of vision, diplopia, ptosis for 6 patients. 3 patients with rhinoorbital cerebral disease underwent treatment C with treatment success in 2 of 3 patients. And the 3 patients in treatment group B with rhinoorbital cerebral disease and 1 patient in treatment group C died due to uncontrolled disease. The mortality was 23.5%. 6 patients ended with no perception of light. The 5 patients had improvement with recovery. 8 patients had improvement with sequelae, and disease is progressive with complication, and death occurred in 4 patients. Discussion, rhinoorbital cerebral mucormycosis is aggressive fungal opportunistic infection in immunocompromised and patients. The COVID-19 pandemic has a widespread sociological and economic disturbances, severely restricting adequate access to healthcare. This has caused decompensation of previously well-controlled comorbidities, patients with chronic illness like diabetes and CKD. We present a case series study of rhinoorbital mucormycosis presence during the ongoing COVID-19 pandemic era. This makes novel. Ours is a multi-specialty government hospital, was a dedicated COVID-19 facility. Patients were seen as a team of departments and coordinate with each other at every level of patient management. Intravenous liposomal amphotericin B is a drug of choice for mucormycosis. In our series, it was administered to all patients. Direct infiltration of the drug into orbit helps in higher level of drug reaching the affected areas. Treatment outcome is good when the disease is anatomically confined to sinuses. In this series, treatment success was 100% in that cases. Infiltration of amphotericin B into orbit and surrounding sinus is beneficial in these patients. In all cases, sinus and palatal disease debridement should be done whenever possible. This would help in reducing the load of infection in the sinuses and also obtain tissues for histopathologic diagnosis. The argument of radical debridement of all affected tissues in a patient with a mucormycosis is based on the capacity of the fungus to spread along the walls of the lumen of blood vessels, leading to necrotizing arteriitis, ischemic necrosis of the involved tissue. The result is poor penetration of systematically administered drugs. All the patients with mucormycosis stage 3 did not do well. All patients in this group at presentations had intracranial diseases, which is associated with poor prognosis. A surgical clearance of all infected tissue, including extendation, is mandatory. Extendation should be prescribed in advance involvement of orbit. So, conclusion, COVID-19 patients, particularly those with uncontrolled diabetes mellitus who are immunocompromised or severely ill, have a higher probability of suffering from invasive fungal infection. Poor metabolic control and impaired renal function were the most common risk factors associated with the mucormycosis. Awareness of red flag symptoms and signs, high index of clinical suspicion, prompt diagnosis with timely initiation of specific treatment, aggressive surgical debridement depending on the extent of involvement, and this is the final outcome. These are my references. Thank you.
How many patients were on systemic steroids?
7 patients.
After your total number was how much? 17.
17.
Of that, 7 were
7
on systemic steroids. And how was the diagnosis of muco confirmed?
By clinically, histopathologically confirmed. All cases are histopathologically confirmed.
So even that sinus one biopsy proven.
Yes, all biopsy proven.
How many had accentration?
3 patients, ma'am.
The total accentration or subtotal?
3 patients.
Was it a total accentration or a subtotal?
Total accentration.
One died.
1 died.
Okay.
Good afternoon. Today my topic is comparison of ocular manifestations of psoriasis with normal healthy individuals, and the rationale of my study is ocular manifestations in psoriasis is always underdiagnosed as we lack routine ophthalmological evaluation in them, and limited number of studies are available focused on the ophthalmological evaluation. So the primary objective of my study was to assess the ocular abnormalities in psoriatic patients in comparisons with healthy controls, and the secondary objective is to investigate possible relationship between ocular surface disease index score and psoriasis area severity index score. So materials and methods include the study design was comparative cross-sectional study, and the study period of 1 year, which was last year, and study subjects include 59 psoriasis patients and 59 healthy individuals, and sample size include 118 eyes of cases and 118 eyes of controls, and the study setting was a Department of Ophthalmology at a tertiary care center in Cochin. Inclusion criteria: the patient referred from dermatology who with a confirmed diagnosis of chronic plaque psoriasis by histopathological examination was referred to our department, who were under the age group between 18 to 60 years. Exclusion criteria: the patients who were not willing for the study, and the patients who already underwent ocular surgery or some ophthalmic procedure. Methodology: the patients with confirmed diagnosis of chronic plaque psoriasis who are referred from dermatology underwent complete ophthalmological evaluation. And using the PASI calculator, we used to assess the severity of the psoriasis area.
And visual acuity was done by Snellin's visual acuity chart, intraocular pressure documented by Goldman's applanation tonometry, anterior segment examination done by with slit lamp biomicroscopy, and fundus examination was done using indirect ophthalmoscopy using a 20 diopter lens or a slit lamp biomicroscope and a 90 diopter lens. OSDA was calculated for a subjective evaluation. There were 12 questions with each question graded from 0 to 4 based on if the patient is having symptoms, which concluded that grade 4 is having all the time, and grade 3 most of the time, grade 2 half of the time, grade 1 some of the time, and grade 0 none of the time. And the total score was calculated using the following formula. OSDA is the sum of scores for all the questions answered into 100 by total number of questions answered into 4. And the score is then graded from 0 to 100 with higher scores representing greater disability. And the tear film breakup time was calculated after staining with sodium fluorescein. The time interval between a complete blink and the appearance of the first dry spot over the cornea was calculated under the slit lamp biomicroscopy using blue filter. Cornea fluorescein staining score was also calculated according to the Oxford grading scheme, with grade 0 no stain uptake, grade 1 minimal stain uptake, grade 2 mild stain uptake, grade 3 moderate stain uptake, grade 4 marked stain uptake, and grade 5 severe stain uptake. Schirmer's 2 test was done, which calculated mild as 9 to 14 mm, moderate 5 to mm, and severe less than 5 mm of wetting. Mebographic analysis was done using the Topcon South Asia Private Limited Autorefractometer, which was an inbuilt non-contact infrared mebography system. And the morphological systems in the mebography were analyzed with computers using Image software. And the amount of mebographic loss was assessed by the dropout area, which ranged from 0 to 100 degrees Celsius and graded accordingly. With grade 0, no mg loss, grade 1 loss of less than 33%, grade 2 loss of 33 to 67, and grade 3 loss of more than 67, and the score of upper and lower lid was summed up to get the MEBO score. Statistical analysis were done using IBM SPSS version software too, and categorical variables were expressed using frequency and percentage. Numerical variables were represented as a mean with SD or median and IQR. And to test the statistical significance of the difference in the median values of continuous variable between cases and controls, Mann-Whitney U test was applied. An independent sample t-test was used to compare the age between cases and controls, and to test the statistical significance of the difference in the proportion of categorical variables, Pearson chi-square test or Fisher's exact test was applied. To find the linear relationship between PASI and OSDI, Pearson correlation coefficient was determined, and its significance was tested using linear regression t-test. A p-value of less than 0.005 was considered to be statistically significant. Demographics, 118 eyes of controls and 118 eyes of cases were used for the study. In comparison of gender with both sex age matched as well as sex matched. And comparison of OSDI with cases and controls were not statistically significant with p-value less than 0.402. And comparison of IOP in eyes of cases with controls was also not significant. And comparison of corneal staining with eyes of cases and controls was significant with grade 0 in cases 31 and in 26.3%, and in controls it was 83.9%. Grade 1 cases 65.3% and control 16.1%, and grade 2 8.5 and 0. And comparison of blepharitis with eyes of cases and controls, of 118 cases of the cases 69 has blepharitis, whereas none of the controls had blepharitis. And of 35 eyes with blepharitis, 88.6% of them had scalp involvement, whereas only 3% of with no blepharitis had scalp involvement. Comparison of mebography with eyes, cases and controls, of 118 eyes of cases, 35 of them had grade 1 mebography, whereas none of them had grade 1 mebography. All of the eyes of controls had grade 0 mebography. That is also statistically significant. The median T-but in eyes of cases was 6 seconds with 25th, and the comparison of T-but in eyes with cases and controls was statistically significant with p-value less than 0.01.
So go to your conclusion slide.
Multiple ocular manifestations were present in our study on psoriasis patients. All objective parameters of dry eye, T-BUT, Schirmer test and chlorophyllin corneal fluorescein score were significantly high in patients with psoriasis, and blepharitis and meibomian gland pathology were more prevalent in psoriasis and had strong association with scalp psoriasis. Subjective scores of psoriasis and that of dry eye has also had a strong correlation. And the limitation of study was most of them were under regular medication, and the symptoms of psoriasis were well controlled at the time of examination, and due to the limitation of time, we were not able to include a follow-up study for these patients, which would have gathered more information. No new cases were also present for the study, and no patients were participated in the study were not taking steroids in any form, so that steroid-related side effects were not included in the study. Psoriatic arthritis patients were not also included in the study, so one of the major ocular association of UV information has not been studied. These are my references.
How do you modify the title of the study?
Sorry, ma'am?
Would you like to modify the title of the study? What is the title?
Comparison of ocular manifestations in psoriasis with normal healthy individuals. So, it's a chronic plaque psoriasis.
This is just a observational study of ocular manifestations of psoriasis, no? You have compared this with the
normal healthy individuals.
Okay.
Actually, ma'am, some of the patients came from the dermatology, complained to the dermatologist that they have some sort of ocular problem. So, they referred, and after that we thought of studying such patients, and we referred to the literature for the same. Most of them are on methotrexate, ma'am. No, poor therapy is not done nowadays in our institution.